Hello, everyone. This is Barbara Wash from Department of Medicaid Services. It is 1 p.m. and I am still clearing the waiting room. Should we give it another minute?
Barb, I'd give it a second. I don't see Ron on unless I overlooked him.
He's not on yet.
Okay.
Okay.
Hello, Rosemary. This is Erin. Do you know if Ron's going to be on today?
Aaron, as far as I knew, he was planning on being
Okay.
on.
Maybe he's like the rest of us in meeting hopping. So,
Mm.
I think Ron just said he's getting on in just a few minutes.
Okay. Thank you, Rosemary.
Sure.
So we have Ron joining right now. Hi, Ron.
Hello,
This is Bar-
can everybody
this
hear
is
me?
Yes, we can.
Apologize for that. I always have a hard time with the link, and today it just kept on dropping. Would you shut that door? Please? Okay,
So Ron, this is Barbara from Department of Medicaid Services. I wanted you to know that we have Matt, Rosemary, Meredith, Paula, Jill, and Philip all here.
okay. All right, thank
Okay.
you.
hmm
All right, let's go ahead and call this meeting to order. I apologize for having technical problems. Um, so we've established a quorum. I never did get minutes from the last previous meeting to send out to you guys, so I will do that. Um, Because had any of y'all received a copy from the last meeting? I didn't think so.
It looks like Barbara sent them out on 9/3,
Okay.
but I can bump those back to you guys.
Yeah, if you can, because it used to, everything came from one person. So now we're getting emails, or I'm getting emails from you, Barbara, and seems like there's somebody else I'm getting it from. So I may have just missed it because I didn't recognize the name.
No worries. I just bumped them to the top of your email.
Okay. Okay. And one old business, if if we want to drop down to Jill's rural health transformation grants. She wants to talk about that while I also um, try to pull that up for everybody as far as the minutes. So
Oh,
do
yeah,
you want,
yeah,
you want
thank
to go
you.
ahead, Jill?
Just last time we spoke, I raised the issue about all the states getting $1 billion from the rural health transformation grants and the RFP process, um, that would be in place. And we did, NACDS did a submit, respond to the survey that Kentucky put out, asking questions about how pharmacy can help expand services in rural areas, which I think we talk about all the time. So I don't think I need to go into detail there. But last time there just didn't seem, it was very early in the process. It didn't seem to be a lot of recognition. Just wondering if anybody from the department has any updates there, and whether or not there are any recommendations about where there is need. And I think the pharmacy TAC can be very helpful to the department as you're sort of batten down the details on your application to HHS, which is due November 4th. Just kind of wanted to throw that out there to see if anybody at the department had any feedback.
Yeah, Jill, thank you for that update. I was just looking at the list of attendees today. I don't know if anyone from DMS can provide a better update than I can. Unfortunately, this is not a topic that I follow very closely. But if you want to send over what you mentioned in writing, I'm happy to get it over to the appropriate SMEs within DMS and get a response for you.
Yeah, and just for on behalf of the TAC members, just so you know, what we submitted was basically very high level about services that all pharmacies can provide. It was not specific to any pharmacy organization or setting. Um, so yes, I'll be happy to send that over, Dr. Ali.
Okay, thank you.
Okay, thanks, Jill. Let me get back to I just sent you all the uh, meeting minutes. I checked on 9/3 in my spam, 9/3 in every other email that I have, and I did not get anything from Barbara. So thanks for resending that, Aaron. So if people want to look over that, but my main point of this meeting today is to again call upon some of the same stuff that I've been dealing with for a while, is that there is not enough providers out there for TB skin testing. Assisted living facilities, skilled nursing facilities, group homes that have the requirement of doing a TB skin test once a year are having a hard time getting people to do it. And the sad thing is, or the good news is, there's a real solution. Pharmacists can do it, but right now pharmacists can't get paid by Medicare or Medicaid. So therefore, a provider who is willing to do the testing can't get paid for it. And a lot of these facilities are obviously Medicaid facilities that I'm talking to, and they can't afford to pay a cash price. So, Fatima, I just wish we had some way, some solution to get this stuff paid for, because I could be doing 1,000 TB skin tests a month if I had the ability to bill.
Ron, let me just jump in here and interrupt, and I apologize, but this is exactly what I'm talking about with the rural health transformation grants. There is the ability for the states to apply and get funds to pay providers for services, way beyond TB testing. Full range of any of the statewide protocols, anything in our scope of practice or beyond what we already have in scope of practice. So just wanted to put that out there. All the things we're talking about, can be part of what the department could push for with the administration, the folks that are writing the grant application under the rural health transformation grants.
Okay, thank you. But anyway, I'm just finding facilities that cannot meet the state requirements for their TB skin testing because of this very reason, is that there's a lot of health departments that aren't willing to do the TB skin testing. A lot of them just say, well, we only do in-house TB skin testing now. People come to us, they don't go to the facility. So there's just a really big deficit right now. And it's not just TB skin testing. There's other things that we could be doing too, but this is just something that's a regulatory nightmare right now for skilled nursing facilities and ALFs. They're having a hard time getting this requirement taken care of. So, and when I talk to a lot of skilled nursing facilities, they're just foregoing it because they can't afford to pay a physician to come in and do it, and have to do it, um, you know, still have to pay them extra to get there, and then be able to hopefully bill it. And sometimes the billing doesn't come through when they're having to pay a physician. They're not being made whole when they're having to pay a physician to get the job done. So I can't impress upon you enough, Fatima, that there's some true deficits and needs right now that could really help out uh, in a regulatory compliance manner.
Sure. Understood from that perspective. Right now, the way our current systems are set up, there are, as you know, some limitations there, and some significant systematic changes that would be required for pharmacists to expand their scope as providers.
Well, let me ask you this.
Mhm.
If a nurse practitioner or physician assistant bills for whatever, how is that totally different from what pharmacists would be billing for? Because
So,
because it seems like to me, if they're providing TB skin testing, or if they're providing services that if it was talked about in the SJ6 or whatever, SJC 26,
mhm.
it seems like to me it's a matter of just adding pharmacists as providers and using the billing codes that are associated for us. Well, I mean, everybody uses the same billing codes for TB skin testing, for example. So it's my simple mind can't get through with, if people are already billing for this, why just adding pharmacists to a provider list? Why is that not a pretty easy fix?
Yeah, so I think there are a few things to understand here. Firstly, that pharmacies currently bill via a point of sale system, and other providers like nurse practitioners, physicians, etc., are billing under the medical benefit, which is not a point of sale system. So when you all adjudicate a claim in the pharmacy system, it yields an immediate result, whether the claim is paid, denied, etc.
No, I'm billing through a medical billing software, just like any nurse practitioner, just like anybody else.
So that would, what you're billing for under the medical benefit, those are likely DME claims, right?
No, I'm billing TB skin testing to secondary and commercial payers, and they're paying it under the medical plan, the medical side of things. We're doing consultant,
Right.
MTM, those type things through the medical billing side. I mean, we've been doing this ever since House Bill 48 was passed and trying to break down those barriers. But
Right.
DocStation, Workflow Services, Enliven, those are three softwares that are doing medical billing.
Yeah, so I understand that. And what currently occurs right now in our systems, right? Pharmacies are provider type 54, and some of you have provider type 90 for durable medical equipment billing, right? So adding that provider type within our systems is, something that hasn't been done yet, and opening up provider type 54 for multiple medical billing codes besides the ones that are currently allowed for vaccine counseling, is a pretty big systematic change. I know it sounds simple to, okay, we need to add provider type 54, but in the past, when it's been done for other provider types, it's a big lift from a systems perspective. And currently, right now the policy is, that pharmacists are not recognized as providers in Medicaid system. So that's where SJR 26 comes in, and where that analysis comes in. So, after we published SJR 26, it's something that's been under discussion. I think that analysis was extremely beneficial for us to see what the system's impact would be, how long it would take, what would be required, so on and so forth.
And I see the steps in the document. Do you have any time frame for implementation?
Yeah, so what we put in the document was about 12 to 18 months for implementation from the point when we start to, the effective date. There's various levels of testing that need to occur. We need to coordinate a lot of things with Gainwell and with our MCO partners to open up that medical billing allowance for pharmacy providers.
It seems like when the dentist asked for this, I don't even, I'm not a dentist, but it seems like it didn't take as long to work with them to get them some extra, um, I guess, procedures and things that they could do. But I know we're talking apples to oranges there, but I just get, I just always get the feeling that, we're that redheaded stepchild and we're always dragging behind, and it just gets a little old because, I don't know what to tell my skilled nursing facilities that really need help right now. I don't know what to tell them because if I tell them, oh, it's going to be 12 to 18 months before we can do anything, they're like, well, I mean, we're out of compliance now, and we got a provider that can actually help out and do something and get the job done and make them compliant. And same thing on their vaccinations. Um, I'm going around everywhere trying to help them out with their vaccination compliance, and we actually can help them out there. But there's still a lot of facilities that are behind on that too. So, yes, go ahead, Kathy.
Yeah, I just wanted to reiterate with what Ron is saying, because as someone who speaks with pharmacists from across the state in different levels of care, this is a real issue. Because, you know, within a certain period of time, I had multiple people calling and I was in long-term care too. And so a lot of those administrators and such are looking for solutions. And Ron is right. We have this, you know, one of the solutions. And it's just a shame that we cannot figure out a way to make this work. And again, he's talking about credentialing a pharmacist and not necessarily, you know, the pharmacy and going through medical billing. So it does, you know, I would love for somebody to sit down and tell me why that's so hard. And I appreciate your response too. But when there's a need, you know, like this, it seems like, you know, we can meet that need, and these facilities and patients need that. So, all right.
Okay. Thank you for everybody's comments. As Jill and Fatima, as far as what Jill brought up, did you give us a timetable on those transformation grants, or are they in the works? Just wanted to get a timetable on that too.
I'll need to check internally on that.
Okay.
Ron, every state's application is due in by November. It's either November 4th or 5th, this coming November, next month. And they're supposed to be approved before the HHS is threatening to approve them before the first of the year, so that states can have kind of a blueprint to move forward with some legislative issues, because states can score higher points if they pledge to update their statutes within the next year or two to expand scope of practice for various healthcare professionals. So they want states to have the benefit of knowing that if they applied for X, Y, and Z requires a statute change, that that the legislature should go ahead and you know, debate that statute change. Now that's not the only thing. I mean, you don't have to, states don't necessarily have to change statutes, but they do need to expand. There's several pots of money, but that's one way to do it, is through a statute update. Another way is just to do it through things like exactly what you're talking about. Interoperability, for pharmacies to be able to bill for various services that are already within our scope of practice, especially in a state like Kentucky, where we have a pretty wide scope of practice under the statewide protocols. So, Ron, I'm happy to send the group some background information. There's an APHA paper. There's lots of stuff online. So I'm happy to share that with the group.
Yes, that would be great, Jill. Thank you.
You're
Just a reminder to all the other PTAC members is, I try to, always send out a reminder for agenda items. So always, do your best to try to think of things to go on our meetings. And again, I apologize for my technical difficulties today, but anyway, thanks, Jill, for your submission, because that was a well-needed conversation there. Is there any other old business anybody's got to bring up? And how about new business then?
Ron, I have an item that I forgot to add for the new business.
Okay, go ahead, Matt.
I think I'm pretty good at catching all the Med Impact emails about updates. So I may have missed this, but when did Claritin D and Retin A go off of formulary? Because it kind of just showed up and I didn't see any heads up about it.
Yeah, so that is a manufacturer related issue. So Bausch Health, who makes the drug and also makes Xifaxan and other products, they are no longer participating in the Medicaid drug rebate program. So that's where that stems from.
Okay, when I tried to run the generic, it was saying I had to build a brand. So is this
I got messaging today too, so I was going to ask that as well.
so is the generic going to get coded to where it's covered, or do they? I don't know. I feel like this was programming issue. I don't know what the correct term would be. Something, is the generic going to be covered, or does it need a PA now?
Let me check. I know some Med Impact representatives are on if one of you can speak to it. But let me check in the meanwhile.
And then is Claritin D, is that off for good? Because I didn't see any heads up about that going off formulary either, and that kind of caught us off guard. I mean, it might have been 2 months by now.
Let me double check if that was on the Bausch Health list.
Is there anybody from Med Impact on the line that would care to comment?
Yes, this is Vicky from Med Impact. So regarding your question about the product and the generic being rejected currently, so because the Bosch product, Bosch like recently became rebatable, so their products started to reject for non-MDRP, non-Medicaid rebatable, and for the alternative, the generics, we are working on reviewing all the alternatives and the generics regarding their formulary status currently. So the messaging you're seeing now is not a coding error, but the updates are still under review.
So do you have an ETA on when we may get an update on the generic versions? Because we've had several pharmacies as well reach out to me on. So in the interim, do they PA the generic? Is that the messaging?
So the generic, the non-Bausch products and alternatives are still they remain their old status. They have the formulary status or the coverage status has not been updated. That's why that generic, the Retin-A generic, is currently non-preferred. We could have a quicker turnaround to update the messaging to stop referring the pharmacists to the to try the brand. But as far as the formulary, like the PDL status update, I'll have to work with the internal team and get back to you on the ETA.
Okay, any word on generic Claritin D?
I need to check on that one. Just give me one moment.
And then I have one last one. I'm having aspirin 81 will go through for Medicaid members, but if it's a dual eligible member, when you split bill it, it's not covered.
Which product was that again?
Aspirin 81. And I tried a couple different NDCs. I was having the same issue.
Yeah, I think if you can send that one to DMS and Med Impact via email, I think that's one we'll need to research a little bit further.
Gladly.
Thank you.
And Vicky, with your research, if you could follow back up through email and let us know what's going on with a few of those products.
Could you send, I was gonna say, could you send us an email with the products that you wanted us to check? I got the Retin-A from Paula, like she already sent us an email regarding the Claritin D. Could you send us an email so I can provide you an email follow-up?
What email would you like me to send it to?
The KYMCL inbox.
I'll throw it in the chat for you.
Thank you.
Thank you. I appreciate your help.
That's all I had, Ron.
Okay, thanks, Matt. Anybody else with new business? Okay. Anybody with general discussion or recommendations? Okay, I always take care of the MAC meeting representation, but on the next PTAC meeting is December 10th. And just pay attention, the very 1st of December, I'll be sending out a reminder for agenda items. So, but anyway, do have a motion to adjourn?
So moved.
Second.
Okay. Was that Paula on the first?
Jill.
Jill on the first, Phil for second. Any further discussion?
No.
Okay. All those in favor say aye.
Aye.
All right. Thank you all. Again, I apologize for the getting on here late.
Thank you, Ron.
Thank you.
Bye.